Hi, I'm Ben and I've been working on this project towards better treatment for people with base of thumb arthritis, and this is obviously the pre-meeting presentation just to summarise a few things I felt were important. So I wanted to cover just a bit about the background of base of thumb arthritis, the impact it has, where we are now in terms of how do we treat it, some of the evidence and what we know about current practice. So hand arthritis represents a big impact upon patients and healthcare services. Over 1.5 million patients have sought treatment. That's 6% of the over 45s. Obviously age is the biggest risk factor for hand arthritis. There are over 1 million GP consultations per year relating to hand arthritis. So hand arthritis obviously can involve any of the joints in the hand. What's interesting is if you look at the work done by Keel here, base of thumb OA in blue, you can see actually the vast majority of patients with hand arthritis do have some thumb involvement. It's almost 90%. It's quite rare to have arthritis just confined to the fingers. We also know that pain and dysfunction seems to be a bit worse if you have both the thumb and the interphalangeal joints involved, so both the thumb and the fingers involved. It seems to be slightly less painful on average and slightly less dysfunctional if you just have the fingers or just the thumb involved. So what are pathways like for patients in the UK at the moment? Well, we don't necessarily really know that well, but there's been a lot of evolution of care in the last couple of decades and things have definitely changed a fair bit. The traditional model was that the patient would go and see their GP, and if the GP couldn't settle the symptoms down, then they'd be referred on to hospital services and a surgeon straight off. Now we have a slight increase in complexity. Patients can still go via this route, but most regions now have interface musculoskeletal services beyond primary care, and patients can be referred there via different means. So patients can be referred by GP, they can self-refer via their GP practice. Some of them have online ways of doing this via their websites. Some GP practices now have physiotherapists, FCPs, working with them who will see patients with hand arthritis and potentially then refer them on themselves. Interface musculoskeletal services are somewhat variable. Some are run by private companies, some are NHS run, some are in the community, some are in hospitals, some are a bit of both. And we obviously did a bit more work on this to try and define what actually does exist at the moment in the UK. So how are patients currently treated? Well, there's a fair bit of guidance out there from NICE and the likes of EULAR. Generally, shared decision making, education, are key parts of the non-surgical conservative measures that people employ. Use assistive devices, activity modification, kind of pacing, how you do things, specific exercises around the wrist and the base of thumb, and then steroid injections. And then there are surgical options beyond that. The most commonly used operation in the UK is called a trapeziectomy, which is taking out the bone at the base of the thumb. And there are other options like fusions or joint replacements, which are less widely used in the UK. In hospitals alone, we spend 4 million per year on around 6,000 steroid injections and 20 million per year on around 6,000 operations, the vast majority of which will be trapeziectomies. We know that hand arthritis and base thumb arthritis are a big priority for patients and clinicians. The James Lind Alliance, which gets patients and clinicians together to work out what are the biggest priorities for research, came out with these two priorities as two of the top 10. So one at the above of those is which interventions give the best results in the treatment of painful joints to the hand and wrist, and the other below is what are the most effective non-surgical methods for treating early arthritis in the hands and fingers. When we were looking into this area a few years back, we did a systematic review, which is basically a way of looking at all the evidence out there on a particular subject, and we reviewed the evidence for injections in base of thumb arthritis. Given it's one of the most common conditions we treat and one of the most common treatments, you'd think there'd be a fair bit of evidence out there. Surprisingly, there was very little, particularly relating to the use of steroid injections. And really, there isn't a single large, well-powered, well-designed study out there, and we just don't know if steroid injections are effective, and if they are, how effective are they and for how long, and are they also cost effective? We just don't know that either. Exercises are a widely used treatment in arthritis in general, and also specifically in hand and base of thumb arthritis. So we did another review looking at what's the evidence for exercises versus a placebo or sham control, and it does appear that exercise is effective, but the effect size, so how effective it is in terms of improving patients' pain and function, the size of this effect wasn't particularly big. And actually the bigger, better designed studies, particularly in the hip and knee, have shown actually there may not even be much of an effect at all of exercise. So I think this is an area which has the potential for further research as well, particularly in terms of base of thumb arthritis. So to try and understand what's happening at the UK in the moment, both in terms of pathways and in terms of patient treatment, we did a project in which we recruited 32 centres in the UK, and we did this in interface centres, so those centres which we defined as taking referrals from primary care, and 11 of these were purely based in hospitals and 21 were community based. We had 24 participating clinicians who were physiotherapists and 8 were occupational therapists. So what did we find? Well, most centres had a guideline for the management of base of thumb arthritis. Quite a few centres referenced the NICE and the EULAR guidance, which I've mentioned previously, and treatment was fairly standardised in some ways. Everyone used education, joint protection and splints. Most centres used some kind of strengthening or functional exercises, and assistive devices were quite commonly used. In terms of other aspects of treatment, there was no universal guideline or threshold for offering a steroid injection. Steroid injections were delivered by lots of different people in lots of different ways, lots of different doses, with variable use of the numbing local anaesthetic alongside the steroid. So we wanted to look at what treatments patients had had before coming to interface services. We had 5 patients from each centre. Most patients had had symptoms for around 12 months, and the majority of patients had had analgesics before they came to interface services. Some had had a splint, just under 50%, some had had therapy, just over 40%, and a small minority had had an injection previously. Most of those who'd had an injection weren't being seen as part of their first ever referral. We kind of then did some basic estimation and worked out that roughly 50,000 new referrals per year in the UK to interface services. So you can probably estimate there's around somewhere probably between 1 and 10,000 steroid injections per year being done in the interface. So what next? Well, I'm going to bore you with some more talks just to summarise the evidence of what we know at the moment in a bit more detail. Victoria is also going to summarise a bit more about the actual therapy-based treatment, particularly in terms of the exercise treatment. We've done a fair bit of work looking at the perspectives of therapists and surgeons around how they manage thumb arthritis and how they see a trial in this area, which I'll also present to you. And obviously the overarching aim is to think about this and work out what are the best research questions here. What should we be asking in a clinical trial? Because ultimately we want to improve treatment for patients, and the best way of doing that is to do some high quality research and answer one or two of the best questions we can come up with. So very much looking forward to meeting you at the meeting, and I hope this hasn't been too boring. Thanks.